Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with John. How are you doing today?
Good. Yeah.
Awesome. So today we're going to be talking about blast lung, blast injury, and you're definitely the guy everyone recommends talking to. So since this is the first time you're on the podcast, would you mind doing a quick introduction of yourself?
Yeah, so I'm John Wightman. I was a EMT back in rural Colorado for a little while, then an inner city paramedic. Then went back to school and eventually ended up in medical school, did my emergency medicine residency in University of Illinois, Chicago, and then joined the Air Force and did 32 years in the Air Force as an emergency physician, either in clinical teaching settings associated with a residency or with the Uniformed Services University, and kind of in and out of law enforcement special operations and military special operations. My last assignment to AFSOC was as the 24th Special Operations Wing Surgeon. And I got interested in blast injuries back in the late 90s because there was very little evidence for it, but these terrorist attacks were occurring. And, you know, when something happens, even if there's not a lot of good literature out there on how to deal with it, you still have to deal with it. And so I did a deep dive and ended up co-authoring a paper on blast injuries in the Annals of Emergency Medicine that came out 3 months before 9/11. And then that just kind of snowballed into a career of learning more about it. I've had deployed to the embassy bombings in Nairobi and Dar es Salaam, then really got interested in it and ended up just learning more about it and really digging into the literature and staying up with it. Kept writing about it, and then with 6 deployments to combat zones, got a lot of experience dealing with it. So that's the quick one. 32 years in the Air Force, retired 3 years ago.
Nice. Well, you're absolutely the dude that we need to talk to about this. So I think maybe to start off, when you're talking about blast lung, like what is it? Why does this happen?
So blast lung injury, well, actually all primary blast injuries, maybe we should just define those just real quickly. Primary blast injury is due to the blast wave itself. Secondary injury is due to ballistic objects, whether that's fragments of the device, added shrapnel, debris from the environment, whatever, and mostly causes penetrating trauma. And then tertiary blast injuries are the blast wind picking up people and throwing them around, and the vast majority of that is blunt trauma. There's a couple incidents of people sustaining penetrating trauma because they were thrown into something that then penetrated them, but most of it's going to be blunt trauma. And then there's quaternary injuries, which is everything due to the explosion that isn't due to a pressure effect. So not the blast wave, not the blast wind, but it's things like burns from a fireball from the explosion, or this is kind of theoretical, but it probably does happen, as almost all explosives are a nitrogenous-based product of some kind. And if you end up inhaling a lot of nitrates, it's just like taking nitroglycerin. It can lower your blood pressure. I don't think anybody really knows how much that affects people. And then there's collateral injuries. A lot of people try to do a quinary injury, or they stuff some other stuff into the quaternary injury. I think collateral injuries is the best term used by Stu Miller, who's somebody who's really done a lot of work in the physics of blast injury. But that's, things like added chem-bio-radiological stuff, or the explosion causes your vehicle to crash. So you've had a motor vehicle crash secondarily. I don't know how many people I had where their vehicle was flipped over into a wadi that had water in it, and now you've got near drowning on top of that. It can be exacerbation of chronic illnesses. It could be, just any other effect that really didn't have anything to do with the explosion, but still is additional problems that you have to, might have to manage. Building collapse is another really good example of a collateral injury, because you can have a building collapse that isn't due to an explosion, but that increases mortality. And then if there's a prolonged extrication, then you still have all the effects of, dehydration. If it was a confined space, maybe, prolonged hypoxia and hypercarbia, because the air isn't being exchanged, dust inhalation. I mean, all that stuff that, and prolonged crush syndrome if you've got a trapped extremity, or something along those lines. So prolonged shock, there's lots of different things that could be. But again, those are kind of all the collateral injuries. So coming back to primary blast injury, that's the entity that is really unique. Everything else is penetrating, blunt, thermal, things that people should be relatively familiar with. But primary blast injury is due to the blast wave effects on the body. And so when there's an explosion, you turn the mass of the explosive, whether that's solid or liquid, instantly into a gas, pretty much instantly, when the same number of molecules in the same space, but now it's a gas. And so it's under extremely high pressure. And then those molecules radiate out away from the epicenter of the explosion, but they're doing so supersonically, and they're pressing against the molecules of the atmosphere, whether that's air or water. You can have a water atmosphere if it's an underwater explosion, but in air, you're pressing the molecules, and you're doing it faster than they can disperse by just, normal thermal motion. And so as that wave compresses, you end up with this band of extra high pressure that we call the overpressure. And it may only be 2 to 4 millimeters thick if you're talking about conventional explosives. If you're talking about thermobaric or nuclear, you can have a really wide blast wave that can completely envelop somebody. But 2 to 4 millimeters thick, when that contacts something, eardrum, chest wall, abdominal wall, that band of high pressure is exerting a force from high pressure to low pressure, and basically just goes pop and pops in the chest wall or the eardrum or whatever it may be. That then sets up another wave that goes into the body, and that wave is called a stress wave. And then that is propagated through, if we're talking about blast lung injury, through the lung, but it's propagated at different speeds through the water-containing tissue and the air-containing air spaces. So then if you're looking at the stress wave as it goes through, if, say, this is water and this is air, they will then start to separate so that it's going faster through the water, it's going slower through the air, and now you have these two high-pressure stress waves. They're dysynchronous, and they're doing this to the alveolar wall. And so that tears the alveolar capillary interstitium, and you get bleeding into the substance of the lung, which also can then get into the airways. And bleeding into the substance of the lung is a pulmonary contusion, essentially. Similar to blunt trauma, but pathologically, it's really probably not that different. It's just that the mechanism is different. Same thing happens to the bowel. So you can tear bowel wall through the same mechanism, and obviously eardrums, get perforated because they don't really have much space to go. So so that's how primary blast injury occurs. The spectrum of injuries can be pretty wide. So if you have a air to tissue tear, two things can happen. We already talked about blood leaking into the airway or into the substance of the lung or into the pleural space. So you get, hemorrhage into the airway, you get the pulmonary contusion that then creates difficulty diffusing air even if the airway is open, and you can get hemothorax. Or the air can go into the tissue, and so you can get what's called a traumatic pseudocyst, where you just get a cystic structure in the lung that may or may not, it's kind of like an emphysema bleb in a lot of ways. It's just created by trauma. Or it can tear out into the pleural space and create a pneumothorax. Or it can inject air into the pulmonary venous circuit, which then can transit back to the left side of the heart and then get ejected out as air emboli, arterial air emboli. It's hard to say quickly. And then those bubbles can then infarct anything they go to. And if it goes to your big toe, it might not be such a big deal. It goes to your brain, your eye, your heart, then it's a real big deal. So those are kind of the mechanisms by which some of these pathophysiological entities occur. And that is really what we want to focus on, because that's not something that you encounter every day. And it's also it not only is an entity that sometimes is not clinically obvious initially, may develop over time, and may complicate your management of anything else they've got, like penetrating trauma or blunt trauma or thermal trauma or anything along those lines. So is that any other questions?
No, absolutely perfect. Because at least my opinion, once I understand what is happening and why it happened, it helps understand all the things I need to watch for and potentially how do I fix what's going on.
Roger.
But what kind of timelines? Like, obviously everything is dependent. Like, is this a hand grenade in a hallway, or is this like a 2,000-pound bomb that we're talking about?
Yeah, it's probably not a hand grenade in a hallway for the most part. Most of the good literature on, kind of what it takes comes from either the troubles in Northern Ireland in the 70s or Israeli literature kind of across the 80s and 90s. To be honest, it's because both groups had a spate of attacks that were in enclosed spaces. So bombs detonated. It might be a vehicle-borne IED outside of a building, but the people were in the building. Or the building itself was attacked, or in the Israeli case, it's commuter buses. And what I've been told in Israel, it's either too hot to leave the windows open and it's all enclosed, or it's too cold and they're running heat and they still have the windows closed. So you get this explosion inside a bus, and then that blast wave is then magnified on the periphery. So when a blast wave approaches a wall, that energy gets even stacked up more before it reflects. And so if you're close to the wall, you even have a higher overpressure than you would if it was just kind of transiting across you. That is until the walls of the building or the bus give, and then the whole thing gets torn apart. But because a lot of people that are inside, like a building, if you have a vehicle-borne IED outside the building, and we're not talking like Oklahoma City where you got collapse of most of the structure, although there is a paper on the children that were in the daycare having primary blast injuries. But the vast majority of the people killed in that were in the collapse portion of the building. So separate from something like that, because that was a 2 metric ton explosion. Yeah. But if you just have a car packed, but you're inside a building, you might be protected from the fragments and any shrapnel that they've put in there. So you're just getting the blast wave effect. But if you're in a room, it's bouncing around the room and magnifying the effect there. In the commuter bus bombings, it might just be a backpack, or a briefcase. And sometimes if you've had to go through security, you can't pack a whole bunch of nuts and bolts and nails and stuff in there to add the shrapnel to it. So there's not a lot of fragmentary stuff going on. And so it's, again, mostly a primary blast effect. And so in the initial survivors, you've got a much higher proportion of primary blast injured casualties. Because if you have a vehicle-borne IED in a marketplace, an open-air marketplace, if you're close enough to sustain primary blast lung injury, you've been just shredded by, fragments and other stuff like that. So there won't be as many survivors to medical care, to encounter. So the percentage of primary blast lung injury is going to be lower in a situation like that than it will be in a closed space without a lot of fragments and a lot of penetrating trauma. And you might see 60% of the initial survivors have some form of primary blast injury, either tympanic membrane, lung, bowel, whatever. If you look at some data from a unspecified NATO Roll 3 hospital from 08 to 13, they did a scrub of the DoD trauma registry and found that of IED attacks in Afghanistan, there's approximately 11% had some form of blast lung injury. The vast majority of them were mild and only really detectable by radiography or seen on CT. But most of those were open air as well. So let's go back to your original question, because I got off on describing it. So that's kind of the epidemiology of it, at least as in conflicts that we have already had. And we certainly don't want to be fighting the last war. I mean, when we talk about confined spaces, first of all, a large-scale combat operation, we may be talking about 2,000-pound bombs, and you might be 100 yards away from it and still sustain blast lung injury. And you just happen to be lucky enough not to get hit by any fragments. And then, like in Ukraine now, trench warfare is a big thing, back to World War I. But a fairly recent study did some computer modeling about blast effects in tunnels, or not tunnels, in trenches. And it's definitely magnified in trenches, but it could be magnified if you had tunnels. And if, we ever had to go underground in a future conflict, then if you've got exposure to the air or an open door that leads into a tunnel into underground, then your percentage of primary blast injuries are going to probably be all the casualties you see, because the fragments, the fireball, the blast wind really isn't going to have much of an effect on them. So the possibility for this to be a large percentage of casualties is,
yeah, I think it's significant. I mean, just with the trench warfare, like actual manufactured bunkers, not just caves or hotel rooms that you happen to be hiding in, but manufactured bunkers, all those things are going up, and we have guys all over that are working out of them right now.
Yeah. So in terms of, you asked how fast this can occur. And so um, from Israeli studies, they found it was actually a secondary measure in one study, but they found that if you didn't have something within the first hour, you weren't going to have something bad. So it can develop over 24 or 48 hours, but if you start developing symptoms in 24 hours, it's going to be slow in onset. You're going to recognize it mostly from unexpected dyspnea. So, dyspnea on exertion, so, you used to be able to, run a mile and now you really can't, or ascending stairs or just walking across the room. That whole dyspnea on exertion scale, people are not going to be able to do what they used to be able to do. And that may be a pretty subtle finding. They say, hey, doc, I can't, do this, that I used to be able to do. Or, when I put on my ruck, I just get totally wiped out. And so that might be a subtle sign that they've got something, but the chance of that progressing to something that they're going to need true intervention on is relatively low. Actually pretty low, at least looking at the Israeli studies. Now, just to quickly mention, though, if somebody you think might have a minor blast lung, if they exert themselves significantly within those first 24 hours, they can worsen the blast lung more than they would have otherwise. Those are some pretty old studies, but it's probably good advice that if you think somebody's got a very, very mild case, they shouldn't be humping a ruck over a hill.
Yeah. Okay. That makes sense. So if it's going to be a significant problem, it'll probably happen within the first 1 or 2 hours.
Yeah. And I would say at the real outside 4 to 6 hours. Okay. So probably by the time, depending on how close they are, but if they get evacuated to, say a safe house or whatever, there's probably some time that has occurred to that point. And I think it'd be prudent to watch them to that 4 to 6 hour point, and just make sure that their SAT's not on the way down, or that, they haven't developed something else. But I think that, if they're out of that first hour or two, they're probably not going to develop to the point where they're going to need mechanical ventilation or something along those lines.
Okay. So let's kind of get into, actual coming up with a diagnosis, clinical findings, et cetera, because especially early, one, you're doing your march and you're looking for all the penetrating stuff. People tend to be pretty excited to begin with, so it's kind of hard to tell if this is difficulty breathing because they've been injured or because they went through a significant event.
Yeah, Roger, you gotta rule out everything else first, because the march is the immediately life-saving stuff, and so we can approach each one of those, MARCHH, but just thinking about it initially, what's going to kill them the fastest? So if if their SATs are super low, you're going to have to do something about that. But really, pneumothorax, tension pneumothorax, and in some studies, a fair higher percentage of bilateral tension pneumothoraces. So, if you look at the way, TC3 looks at pneumothorax, we're kind of looking for some asymmetric signs sometimes. I always, teach, asymmetric breath sounds and shock equals needle, but it can be bilateral. So the criteria, progressive respiratory distress along with shock, but then choosing which side. If you've got ultrasound, absolutely use it, because that'll tell you which side to put the needle in, or both. Now, both, you can probably get away with needle-wise, but the chances if they've got bilateral tension pneumothoraces, they probably have a bronchopleural fistula. So somewhere in the trachea or bronchus within the chest is now leaking out into the pleural space. And that's actually an open tear. And if you inhale some tidal volume, or with positive pressure, you bag them with some tidal volume, a good percentage of that air is just going to shoot into the chest. And 1 or 2 needles is never going to evacuate that. And then you're talking about, finger thoracotomy, and then the patient can no longer have a negative pressure inhalation on their own, and you're pretty much committing them to positive pressure ventilation. And that's okay, because the tension pneumothoraces or pneumothorax singular is going to kill them within 5 minutes. And so, get that stuff out of the way first. And then if they've got a persistently low SAT that isn't otherwise explained, start thinking about blast lung injury. Now, there are some ultrasound findings.
Just one real quick question about in the March sequence. I suspect, they have low SpO₂. Their breathing is not getting easier. It seems like it's progressively more difficult. Would I be wrong just to do either a needle Ds bilaterally or finger thoracotomies? Assuming I don't have ultrasound, I'm essentially just working out of my March belt aid bag kind of thing.
You would not be wrong at all, because again, there's much less you can do about blast lung injury in the field, and lots you can do about pneumothorax and a developing tension. So absolutely not wrong about it at all. And if all they had was a pulmonary contusion and they had shock from another cause, all good. It really is. A mistension pneumothorax is absolutely a preventable cause of death. I'd not be wrong at all. I don't, in my opinion.
Obviously, everything we do in medicine has a consequence, but the how bad you can go wrong by failing to treat a possible tension is obviously it's fatal. If you do it and you happen to be wrong and he didn't have a pneumothoraces, well, now he's got an extra hole in his side, so you get to deal with that. But
I would back up anybody who made that decision.
So I'd say we're kind of getting out of the March stuff, getting into, hey, we have a little more diagnostic stuff, maybe an ultrasound, or we just have more things at our disposal, right? Mm-hmm. What other things would I be looking for beyond, the immediate stuff that says, hey, this guy has a building blast lung injury?
Yeah. So primarily it's just going to be, decreased SATs and progressively decreased SATs over that first time period, so trying to, categorize how bad this may be, there's some different ways of approaching that. So probably the thing that's been looked at the most is the PaO2 to FiO2 ratio, which I'll just call PFR. So in the JTS CPG for acute respiratory failure, they talk about ARDS and categorizing that ratio. And this comes from ARDSNet too, but they use 300, 200, 100, as like categories. So 300 to 200 is mild, 200 to 100 is moderate, 100 and down is severe. When you're calculating a PaO2 to FiO2 ratio, it has to be an ABG, and ISTAT's fine if you're going to do an ABG, but it really has to be arterial blood. And the FiO2 has to be a fraction, not a percent. So if you're on room air, then it's going to be 0.21, okay, as the denominator. So, that would be, so like if you're, say your PaO2 is, I don't know, let's say 50, and you divide that by 0.21, then your PaO2 to FiO2 ratio would be 250, approximately. I'm doing this in my head. So as long as you're using a fraction for the FiO2, it's pretty easy to calculate. A study out of Israel looked at their bus explosion primary blast lung injury people, and they used a PaO2 and FiO2 cutoffs of 260. 200 is one, 60 is another, not 260. So if you're above 200, then none of their patients needed positive pressure ventilation for a respiratory reason. So they might have needed it because they needed to go to surgery or something like that, but they didn't need it because of respiratory failure. If they were in the 200 to 60 range, all of them needed positive pressure ventilation for at least one day. And many of them just for one day, just to kind of get over the hump. But they could use standard ventilation techniques. So reasonable tidal volumes, that are lung protective, PEEPs that weren't up more than 10. Usually you start at 5, but, they didn't have to go up higher than 10. Volume controlled ventilation, so just the standard way the 731 is set up. People who were 60 and less were considered severe, and they all needed positive pressure ventilation for at least a day or more, but a lot of them needed fancier ventilation strategies like pressure-controlled ventilation or high-flow jet ventilation or oscillatory ventilation or nitric oxide therapy or even ECMO. Yeah, they weren't using ECMO back in that study, but other studies have said that ECMO, can be used for really badly injured lungs. None of which you're probably going to be able to do in a prolonged field care environment. The 731 will do pressure-controlled ventilation, but even I wouldn't even try to do that without getting on telemedicine, very early, because just even setting the thing up is difficult. And if you're using pressure-controlled, you're only allowing a certain amount of pressure, which means that the tidal volume can be cut off less than what you want. So in volume controlled, you set the tidal volume and you're watching the peak inspiratory and the plateau pressures. Pressure controlled, you're looking at the peak inspiratory pressure, and that's what you're setting, that it doesn't go above a certain level. But then if it pops off and the tidal volume, they only got 200 milliliters, then that may not be sufficient. So, and how to set it up on the ventilator, I would have to assuming that you have communications in the tactical environment that you're in. But yeah, it would be, I'd be hard pressed to do it because I just don't do it all the time, and you need somebody who does it all the time to kind of help you track that. Because, in normal ventilation, you don't have to do an arterial blood gas every time. You could just do, a venous blood gas, to kind of track, and then end-tidal CO2 if you've got them on positive pressure, in a closed circuit, But again, you can use VBGs, periodically, and maybe do an arterial occasionally. But
that's what I was going to ask you is all like our iStats. Generally, we're doing VBGs, and it converts to some kind of arterial readings, like through the algorithm, right?
Yeah.
So it gives you a PaO2, but it's like it's gone through some kind of mathematical formula.
I wouldn't use. I think you can use VBGs to see if it's trending in the wrong direction or in the right direction. But the conversions, I'd be a little careful of, particularly if the patient's in shock, because all these people with blast lung injury could have penetrating abdominal trauma too, or penetrating chest trauma. So, and that shock moves the oxygen hemoglobin dissociation curve, and then those calculations are off. So I would only kind of use it for trending and not for the calculations.
Actual numbers.
Probably. Yeah. But coming back to the mild, moderate, and severe, in terms of, you're trying to figure out who might need positive pressure, you can do a SAT conversion of the PaO2, assuming that the curve hasn't moved, but you can kind of get a general gestalt. So if somebody is satting better than 75% on room air, and this is assuming that you're not at some significantly high altitude, but if they're satting better than 75% on room air, they're probably in the mild category. Okay. And 75% is pretty low, but if they're breathing on their own and they're not really struggling, and maybe a little supplemental oxygen helps them if you've got that available, then they don't probably need to go on positive pressure, at least not right away. And that's going to conserve your resources over time, and not commit this person to positive pressure, which also commits your personnel resources to watch them, all that stuff that, the audience definitely knows.
One quick question.
Yeah.
So you mentioned PaO2 of greater than 75. Would that extrapolate to an SpO2?
No, that's what I was saying, is SpO2. Yeah. So your pulse ox 75% on room air or higher you're probably in the mild range, looking at the Israeli data. So you're probably over 200 in a PaO2 to FiO2 ratio. Okay. So those people probably aren't going to need positive pressure ventilation. If you put them on a non-rebreather mask and they're in the 75 to 90 range, they're probably in the moderate range, and they're probably going to need positive pressure ventilation somewhere along the line. Clinically, you need to look at them and say, do they need it right now? Or can I deal with these other casualties and then, come back to this person? Then we can do it in a little more staged manner. Okay. And if they can't maintain 75% on a non-rebreather, then you're probably talking about they need positive pressure probably pretty soon.
Take their airway.
But one of the things about blast lung injury is that positive pressure can be bad. So we want them breathing negative pressure, spontaneous ventilations, so you expand the chest, negative pressure pulls the air in rather than us pumping the air in. There is some experts from World War II that wrote that the people that they put on positive pressure rapidly died. And they're just case series. They're not, we don't know what the percentage of that is, but the theory is that you increase the risk of arterial air embolism because you're doing positive pressure. It's going out the broken capillaries or broken alveoli into the capillaries and then getting circulated out someplace. So we really don't know for sure that that's the case because, there wasn't a lot of autopsy data back then. And it's really hard in an autopsy to detect arterial air embolism, unless you can actually see it through the vessel wall. Because if you don't do it underwater, there's no bubble up. And so, it's just really tough to diagnose. But that's the theory. So those people in the mild category, you definitely don't want them on positive pressure. And even the people in moderate category, if they're doing generally okay on their own, you don't have to put them on positive pressure just because they're in the moderate category. But, so if they're on a non-rebreather and, you get them up into the high 80s, that might be fine. The other thing is that CPAP, continuous positive airway pressure, has been shown to be effective in blast lung injury. So a non-invasive positive pressure is a potential move as opposed to intubating them. Bilevel airway pressure, positive airway pressure, I haven't seen any like reports that it works, but you'd think it would if CPAP would work. So, I think that that's an option, and the 731 does do that. So that might be an option to go to for those, those people that are kind of on the fence and you're not really sure, but they seem to be doing okay clinically for now. And then you're not really committing quite as much resource to it, other than you're tying up a ventilator. But again, you don't want to go to it if you don't have to. But if you have to, and it's not emergent, then I'd try the non-invasive first, and then if you have to intubate them, you have to intubate them.
Sure. So does PEEP help?
Yes. Yeah. So when you turn on the ventilator, it starts at 5, and we generally go up like 2.5 at a time, but yeah, you can add a little PEEP, and up to 10 is considered that's okay, particularly if it's a short-term thing, because that allows you to decrease the amount of oxygen, the percentage of oxygen, the FiO2, you can decrease that. And if you've got to hang on to them for a long time, then you don't run into the problems with oxygen toxicity. And so it's okay to go up on PEEP. Now, if you're going up more than 10, then you start getting into the criteria for ARDS. If you look at the JTS CPG, it outlines that pretty well on, what pH, what PCO2, because as injured lungs are stiff lungs, and so it's harder to ventilate them. And if we're going up on the pressures, then we're running them more of a risk of barotrauma and creating a pneumothorax or tension pneumothorax down the line, as opposed to having it right away. And as you are going up on those pressures, then you do have to start worrying about an ARDS-like picture. And there's not a ton of literature on how we manage blast lung injury in the ICU and what we've tried and what works best, and so we have to kind of come back to the ARDS literature, and really all the interventions are pretty much the same. So, that acute respiratory failure CPG is really quite good, and can really help with some initial guidance before you might be able to, get on telemedicine or call Advisor, which I think is a great resource.
Yes. Call somebody who knows.
Yeah, exactly. And again, somebody who does it a lot, No,
I guess my thought was not necessarily with positive pressure ventilation, but just adding a PEEP valve to the BVM and let the patient breathe through that.
I think, yeah, absolutely. PEEP valves are good, particularly if you're going to end up doing it for a long time. So when we're talking about ruck truck, levels of care, you may not have the ventilator, and so yes, PEEP valve for sure. If you're struggling to maintain their oxygenation, you're sure you're getting some chest rise with your bag. Absolutely use it.
One thing I forgot to ask when it comes to like diagnosing, we mentioned using the ultrasound to find like pneumothoraces or potential tension. Can I also use that to look for like the consolidation of the blood and the edema within the lung?
Yeah. Using
ultrasound.
Yeah. So there's a couple of findings for blunt pulmonary contusion anyway. That's where most of the literature is. So increased or increasing beeline artifacts is probably the biggest one. We could link a couple of papers, or at least one that shows some other things. There's sea lines with pleural gaps, and there's these funky little spaces where you have, and all this assumes that the lung is touching the pleura, because if it isn't, then you can't use any of that stuff. But assuming that they don't have a pneumothorax, you can get these little fluid-filled spaces next to the pleura, and then these, so that'll be hypoechoic, and then there's hyperechoic, like little clots and things. Personally, I've never seen it, so I'm relying on the literature too, but there are some articles that'll show some pictures of what you can look for. But really, increasing B lines are probably the biggie. So the same stuff you do for pulmonary edema will also work for contusion. Again, assuming that there's no pneumothorax on that side. Sure.
And then we talked about, when to ventilate, when to start to maybe take their airway. What kind of goals are we shooting for when it comes to oxygenation and tidal?
Just improving oxygenation to some level. Now, the CPG talks about 88% being kind of the low end, and I think that's very reasonable. But if if it's a concomitant head injury, you got to be higher. If it's shock because they're bleeding or have bled into their peritoneal space or their chest or whatever, then it's probably got to be higher too. There was an interesting animal study that we use permissive hypotension to some degree. They actually looked at a swine model with blast lung injury and prolonged permissive hypotension, and they didn't do well. So you might have to also work on their perfusion and their pressure. And again, particularly because of head injury, you want to have their systolic pressure up to 90 or 100, and if they've got blast lung injury, that might be difficult because more fluid means more edema in the lungs. So, blood's going to be better than, or like whole blood is going to be better than, crystalloids in that respect. If all you've got is crystalloids, then, little tiny boluses, no more than 500 at a time, to try to work your way up slowly, to have a reasonable pressure. So, but in terms of, ventilation parameters, again, that 88, 90, 92 is probably a good SAT to shoot for. The end-tidal CO2, ideally, it's 35, 48, 45, but permissive hypocapnia, so, allowing their CO2 to rise in order not to deliver too much pressure to their lungs, is also a real art form. And again, I'd be doing this if at all possible. And if you find it, and then really, I would say that the trends are better than isolated values. So if you haven't made any adjustments to anything and their SATs are going down, then you need to, look at ways of improving oxygenation. If their CO2 is going up, and you can't use a VBG for that, you have to actually use arterial gas to look at that. If there's CO2, and you can use end-tidal to also trend, but you can't. I don't like to use it to determine, when I make a change, how much change I've made to the ventilator. So, but I think, especially for the medics, the key parameter there is the minute ventilation, and not necessarily just the tidal volume or just the rate. So the minute ventilation is those two parameters multiplied, and it's displayed on the vent down in the lower left corner. But that's what needs to change. So if your CO2 is rising, then you need to increase the minute ventilation. And so you can do that through increasing the tidal volume or increasing the rate. And so increasing the tidal volume probably is not, if you start at 4 to 6 milliliters per kilogram, estimated ideal body weight, as a lung protective strategy to start with, rather than, 7 to 8 milliliters per kilogram. If you start in the 4 to 6 range, if you start at 4, you can kind of go to, work your way up towards 6 maybe. But if you start at a 6 and you're starting to get into the higher ranges, then you're got a higher risk of barotrauma, And so you got a little wiggle room on tidal volume, but rate is probably, a better way to go in some settings. I mean, like I say, you can kind of go up on tidal volume a little bit. Rate, you got more room to go, I think. But as you increase the rate, you can get to a point where they're not exhaling fully, so you got to be careful of that too. So, ventilator training, I'm an emergency physician. We put people on ventilators. We don't do it a long time. I mean, I'd had 3 CCAT deployments, and I knew that ventilator in and out for those, but I haven't done that in a long time, and so, if I was deployed again, I would be spinning up on that ventilator and just hoping I have a respiratory tech who's good with me.
Make friends everywhere you go.
Yeah, exactly. So, anyways, did that answer your question? Okay.
So you mentioned air embolisms like multiple times.
Yeah.
I've never treated anybody that wasn't on their back and stayed there. So would it be safe? I think with air embolisms, you put them on their left side.
Yeah. So this comes from the early days of thoracic surgery, like the 30s and 40s. But if you put somebody head higher than heart, then you absolutely increase the risk of air embolism to the brain. Okay. There is a theoretical concept that if you put them on their left side and then another 45 degrees toward prone, that you put their coronary arteries at the lowest point coming off their aorta. And that theoretically will decrease the risk of air embolism to the heart. The other concept is if you know that they have one side injured worse than the other, you have a pulmonary contusion worse on one side than the other. And, just as an aside, you see a lot in the literature about the butterfly contusion on X-ray. If the blast wave came in from your side, you don't see that. All the pulmonary contusions on this side, and you may have some on the other side because remember that blast wave hits one side, then it wraps around the body, and is still a high pressure band creating a force going both ways, and so it pops in this side, but then it also pops in this side. So it's almost like a ringer effect going all the way around the body, but then it'll push in on the opposite side. So when we do look at X-rays, we look at how many lobes are involved and whether it's asymmetric or symmetric, and so there's some other criteria, but again, not going to probably have X-ray. So if you know that one side is involved more than the other, if you put that side down, you increase the pulmonary, venous, and capillary pressure, which makes the gradient from the alveoli pressure, the airway pressure into the capillaries greater and might decrease the risk of arterial embolism. But the only thing we can say definitively is head at level of heart. And so, those other things, progressive pulmonary contusion that's getting really, really, really bad, and similar to ARDS, proning might help, but that's not an immediate intervention, but that's, maybe down the line. Also, definitely, I would talk to people about that, but that is an option. But in terms of arterial embolism, we can't really say, for sure. But it's not like a decompression illness in that, it's not coming out of the tissues. It's actually going through the vasculature directly.
Okay. All right. Perfect. When it comes to blast injury or blast lung and the management of, is there anything else that we're missing that you just wish people knew better?
Yeah, it's really the positive pressure ventilation only if really necessary. It's being very judicious on your fluid management. Don't miss attention pneumothorax. That's really the upshot. Now, I think that, because, there's often no external evidence, you just got to think about it. And so if you look at like tympanic membrane rupture, it only takes like 5 to 7 psi over atmospheric pressure to rupture 50% of the exposed TMs. Now, if you're wearing some kind of ear protection, it might be higher, but that 5 to 7 psi is enough to shatter windows in vehicles and snap telephone poles. So, it doesn't take a lot, but it takes a lot more to injure the lungs or bowel, like 25 psi, to injure 50% of the lungs in animal models. So if you look and find a TM rupture, it doesn't mean, it's not a marker of blast lung injury, but it does absolutely show you that they are exposed to blast. And then you want to run the MACE-2 on them, and because the the head's going to be affected. And there's a lot of theory about how the brain is affected when there's no penetrating trauma or no blunt trauma, but we don't have to get into all those theories. But one of them is the chest being compressed and blasting blood up into the jugular venous system, and basically you get a water hammer effect against brain tissue. Again, there's a lot of other ones, but it can be all involved. So if you see a tympanic membrane rupture, yeah, they were exposed to blast. If you don't see it, it doesn't mean that they weren't exposed to blast. So if they had a blast, then, or they were around one, you got to at least ask them some questions and think about it. The other one is that, not related to blast lung injury, but blast intestinal injury, is that you can get immediate ruptures of generally the colon, but it can be the small bowel or stomach. But you can also get delayed ruptures because you can get a contusion in the bowel wall that over time weakens and then it perforates. The longest time after the exposure that there's a known perforation was 8 days. Now the vast majority of them will be in the first 2 to 3 days if they're going to get a late rupture. So anybody who has got any abdominal symptoms at all, so abdominal discomfort, nausea, tenesmus, the urge to defecate is a high yield symptom if they have it. Hematochezia, either by report or on exam, are important findings that they might have blast bowel injury or blast intestinal injury. And if you're in a prolonged field care setting, then peritonitis and sepsis, down the road. So again, they may not have any external penetrating injuries or other reasons to be septic, and you got to think about that one too. So, but most of those people will also have blast lung because assuming that they're not underwater, and that's another. If we want to get into underwater explosions and people treading water, all of their abdomen is underwater. Only a small portion of their lungs are underwater, and their TMs are not at all underwater. Probably unless they're scuba.
They're bad at treading water.
Yeah. So or in some flotation device, but so there's a lot of good World War II literature out there that describes just abdominal injury, and very little lung injury. And the other thing about underwater explosions is that the fragments aren't going to travel very far, and there's really no blast wind to throw people around too much. But the blast wave, being in a fluid density, can travel much farther and still maintain its energy for a much longer distance. But you got to be careful about the abdominal stuff, even in the people who have the blast lung injury. It just might be another occult problem without a lot of external evidence to suggest it. Yeah, I would say that just get on the acute respiratory failure CPG, and let that guide you. Again, they use different cutoffs for that PaO2 to FiO2 ratio, but I think that using the 200 and the 60 from the Israeli data is a good place to just do a quick categorization, and then if you have to monitor them for a longer time, then switch over to the ARDS net stuff that the CPG is based on. Excuse me. The other one is that if you're talking about resources and retriaging, ARDS, there's a study out there that if they improve when you go on positive pressure. Now, this isn't a hospital ICU setting, but if they improve when they go on positive pressure, like 94% of them end up surviving. If they don't, then the survival rate goes down. I don't remember the exact number, but it's like in the low 80s or something like that. If you look at the data from that retrospective study of NATO Role 3 in Afghanistan, the vast majority of the people who actually had radiographic documented blast lung injury, which was about 11% of all casualties in that that they looked at, that they had complete data on. But of all those people, like 3/4 of them were in the mild category. And so very few of them needed to go on positive pressure ventilation, relatively. And only one needed something beyond standard volume controlled ventilation with some PEEP. So in the Afghanistan setting, where it's mostly outdoor IEDs and relatively small IEDs compared to, aerial bombs or artillery shells, big artillery shells or whatever a drone can deliver, then those people, the vast majority of them, you're not going to have to put on positive pressure ventilation. And the ones that you do, you're probably going to be able to manage just fine, as long as you've got the resources to do it.
Well, awesome, John. I really appreciate you jumping on.
Yeah, no, I'm very happy to do it. It's a topic that's kind of near and dear to my heart, but just because I've seen a lot of it, and you just If you don't know to look for it, you're going to miss it. Yeah. It's just like a tension pneumothorax. If you don't know to look for it, you're going to miss it. So I hope that this enables people to at least think about it and think about it before they deploy. Make sure that they've got the equipment, resources, knowledge, skills, training to be able to intervene on it, particularly if we get into something that where it's going to be more likely.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.